各位贵宾、各位线上参与的伙伴，大家平安。我们的研讨会
Ladies and gentlemen, good morning. Our conference will start momentarily. Would like to remind those participate in the conference, if you want to apply for credits, please scan the QR code. We provide simultaneous interpretation. You can select the channel to listen to English or Chinese interpretation. If you are joining us on the YouTube, you can select Chinese channel or English channel. We also have a survey as well as after conference test. So after we close the conference, you can fill out the survey, and the test that should be filled out by those who want to apply for credits. Thank you. Ladies and gentlemen, International Online Conference on Smart Healthcare Technology and Patient Safety is called to order. Good morning. This year's marks 125th year's anniversary for Changhua Christian Hospital. We are very honored to organize this conference with Taiwan Patient Safety Club, and we are very honored to work with the Changhua County Public Health Bureau. On many fronts, we are very honored to have speakers from Taiwan, Japan, the United States, and Thailand. We hope that you will find this conference a rewarding experience. To begin our conference, we would like to have Superintendent Chen to say a few words.
Distinguished guests, speakers, moderators, ladies and gentlemen. Welcome to join the 125th anniversary of Changhua Christian Hospital's International Online Conference on Smart Healthcare Technology and Patient Safety. Changhua Christian Hospital was founded by Dr. David III in 1896. After more than 100 years of evolution and growth, Changhua Christian Hospital has become the most historical medical center in central Taiwan. Upholds the spirits of Christ Jesus, selfless dedication, and humble service. Changhua Christian Hospital continually strives for innovative medical research and outstanding medical quality and provides comprehensive care to our patients. This year marks the 125th anniversary of Changhua Christian Hospital. Changhua Christian Hospital is honored to co-host the International Online Conference on Smart Healthcare Technology and Patient Safety, with Taiwan Patient Safety Culture Club to celebrate it. Especially thanks to the Ministry of Health and Welfare, Taipei Economic and Cultural Office in Thailand, and the Changhua County Public Health Bureau for long-standing support to Changhua Christian Hospital. This time, we invite professional speakers from healthcare institutions, industries, and educational institutions in the United States, Japan, Thailand, Joint Commission of Taiwan, and the Taiwanese Society of Biomedical Engineering to share patient safety care with the scientific-based approach, innovative technology, and best practice. There will also be an opportunity to network and explore the various aspects of the creative ideas in enhancing the international competitiveness of medical quality through this online conference, especially during the post-pandemic era. We are humbled and honored to have the Patient Safety Movement Foundation 5-Star Hospital Award. The Patient Safety Movement Foundation have presented awards to 11 hospitals worldwide, and the Changhua Christian Hospital is the first one in Asia. Sincerely thanks to Dr. Mingi, Chen, Liao, as a delegate of the Patient Safety Movement Foundation for awarding and the encouragement from CEO David Mann. All the staff in Changhua Christian Hospital will keep devoting to patient safety commitment to preventing harm that occurs to patients. Lastly, I would like to express my sincere gratitude and appreciation to all honorary speakers, distinguished guests, and the participants. I hope you enjoy and may God bless you all.
谢谢院长的勉励。那接下来我们要欢迎外交部驻
Thank you very much. Now we are going to have Deputy Representative of Taipei Economic and Cultural Office in Thailand.
Director General Dr. Yuan Hong Ye, Dr. Nina Kang, all the distinguished speakers and participants, ladies and gentlemen, good morning. On behalf of the Taipei Economic and Cultural Office in Thailand, it is indeed a pleasure for me to be invited to join you today and to speak here. Firstly, I'd like to congratulate on the 125th anniversary of Taiwan's Changhua Christian Hospital and express our great appreciation for its long-lasting efforts and contribution in delivering medical care and assistance to those in need. The Changhua Christian Hospital has been an important and active role in building Taiwan's global medical cooperative partnership to highlight international medicine and health agenda. In recent years, under our government's new southbound policy, the Changhua Christian Hospital has been designated as the pivot for furthering an extensive and substantial Taiwan and Thailand medical cooperation. Both sides are working together to advance innovative medicine and cross-sector collaboration. As the COVID-19 pandemic continues to spread and affect people's lives and stabilization of medical and health system, we have seen how innovative technology is working to enhance the effectiveness and resilience of policy and system and secure the safety of medical personnel and patients. Therefore, it's especially meaningful for all of us to gather here to address the role of medical technology to the safety of patients amid global pandemic crisis. The conference today will provide a platform for both sides to share good practice and expertise. More importantly, to build a solid mutual support to fight against the coronavirus. Taiwan has enjoyed an advantage of high technology advancement and successfully employed it to pandemic control and prevention, and further secure medical system from weakening since the outbreak in 2020. We see the same path for Thailand heading toward. Our office will continue to play the role of promoting a closer partnership between Taiwan and Thailand, and we look forward to jointly exploring more opportunities of medical and health cooperation. Finally, I'd like to wish the conference a successful one. Thank you all very much, and please stay safe and healthy.
谢谢副代表的鼓励。那接着我们要欢迎
Thank you very much for your encouragement. Now would like to have Director of the Changhua County Public Health Bureau to say a few words to us.
Hsu, distinguished guests, ladies and gentlemen. On behalf of the Changhua County government, I would like to express my sincere congratulations to Changhua Christian Hospital for its 125th anniversary. Changhua Christian Hospital is the most historical medical center in central Taiwan, uphold the spirit of Christ Jesus' selfless dedication and humble service for the patient. Today is the day Changhua Christian Hospital and Patient Safety Culture Club co-host the International Online Conference on Smart Healthcare Technology and Patient Safety. Expert speaker will share the experience about patient safety with an aim to improve the quality of care in hospital. Congratulate Changhua Christian Hospital for having 5-star hospital award in 2020. The Patient Safety Movement Foundation has presented award to 11 hospitals worldwide. The Changhua Christian Hospital is the first one in Asia. There are 18 action plans for patient safety, such as the safety culture, hand hygiene, hospital-acquired infection, medication error, patient blood management, hand-off communication, fall prevention and airway safety, etc. Each action plan demonstrates the leadership and teamwork of Changhua Christian Hospital and witness the commitment to improve patient safety. It is my pleasure to fight against the COVID-19 pandemic in collaboration with Changhua Christian Hospital. And it is my honor to be an opening remark speaker. I wish Changhua Christian Hospital to be the benchmark of patient safety worldwide and bless today's conference successfully. Thank you.
谢谢局长的勉励。
Thank you very
Thank you.
much for the Director General's remark. This year, we are very honored to receive the US PSMF's 5-star hospital. There are 11 hospitals that receive this award. CCH is the first hospital in Asia to receive such an honor. Without further ado, I would like to pass the baton to Mr. Hsu-Tung Chang, Deputy Director of Hospital Quality Management Department at CCH. Ladies and gentlemen on the line, as Superintendent Chen and Director Ye's remarked, CCH is committed to our own safety of the patients. So therefore, when we promote the patient safety and the activity program to make CCH as a highly regarded hospital. Next, we are very honored to, with a humble mind, to receive the award from PSMF with a 5-star award. First of all, we would like to invite David Meyer to give us a remark. What it means is
CEO of the Patient Safety Movement Foundation. We are a global organization in 64 countries and almost 4,800 hospitals around the world. Our vision is zero preventable harm by 2030. It's great to be joining you virtually at your annual meeting, but most importantly, it is my honor to present our 5-star hospital award to Changhua Christian Hospital for their commitment to zero preventable harm. Over the last number of years, they have implemented many of our actionable patient safety solutions that have resulted in them saving lives and helping us strive to zero preventable harm across the world. In particular, I wanted to thank Dr. Liao and Dr. Chang, whose work contributed to this outstanding award. I hope you all have a great meeting and thank you for all you're doing to make care safer around the world.
Next, I would like to invite the PSMF's Taiwan representative, the founder of Taiwan Patient Safety Club, Cultural Club, Dr. Mingi Chen Liao, who is the pioneer of the patient safety. Let's welcome Dr. Chen Liao Mingi.
Good morning, everyone. I am Dr. Chen Liao from Taiwan Patient Safety Cultural Club. In my role as ambassador of Patient Safety Movement Foundation in Taiwan, I feel very honored to be a part of this award presentation. Initially, we had a plan to host this ceremony in a hybrid fashion, and I was supposed to MC the live action of presenting the award to the superintendent on behalf of CEO David Mayer. But at the end, the awardee preferred to do it entirely virtual. So anyways, today I'm particularly gratified to congratulate Changhua Christian Hospital for achieving the 5-star status. This prestigious recognition has made our members so proud. In my observation, this is no small accomplishment. This year marks the 125th anniversary of Changhua Christian Hospital since its founding in 1896. In that spirit, please join me to commemorate the highlighted milestone on this special occasion. I also want to take this opportunity to thank PSMF for the support always. We are reminded of our mission, that is to achieve zero preventable death by 2030. I know we still have a long way to go, and we need each other. Finally, I wish the winner unlimited success in the future. Good luck on the journey to zero. Once again, congratulations.
恭喜张基，也谢谢我们的2位颁奖人。那接下来我们要进入今天的研讨。
Next, I would like to go into the presentation. The subject this morning is the high fidelity and the artificial intelligence on the patient safety application. So the moderator is again Dr. Liao Mingi, who is the founder of Taiwan Patient Safety Cultural Club, who is Ren-Ai Social Welfare Confederation's chairman and the PSMF ambassador in Taiwan. In 2012, he founded the Taiwan Patient Safety Culture to nurture the visitor of patient safety advocator, who is there no time to promote the safety. So now I will pass the microphone to Dr. Liao Mingi. Your microphone is mute.
This one, okay.
Yes, we can hear you. Thank you.
Good morning again. As co-organizer and moderator of this session, let me welcome all the attendees to this virtual conference. Because of our government's southbound policy, we are expecting some international friends to join in online. So now let's start our first session. I am Dr. Zhang Liao from Taiwan Patient Safety Cultural Club. Our first invited speaker is Dr. William Wilson from the United States. He will talk to us about high reliability and artificial intelligence in patient safety. Before I read out his profile, I want to tell you how I became acquainted with him through several activities organized by the Patient Safety Movement Foundation over the past few years. Dr. Wilson is not a new face to many of us, especially after our folks and I went for the so-called mentor program with a site visit in 2019. After we show all the pictures, I think many of us know about Dr. Wilson. UC Irvine Medical Center actually co-hosted our study tour, and we owe him and his team a lot. Thanks again. So let me quickly profile his curriculum. First, he graduated from Temple University, that's in Pennsylvania. So previously, he has worked as vice chairman of anesthesiology and chief in the division of critical care medicine at University of California at San Diego. Dr. Wilson has authored and edited several major textbooks. He was the CMO for UC Irvine Health for several years until last month. Currently, he's the Senior Vice President and CMO also for the Masimo Corporation. Under his leadership, UCI Healthcare became the first academic medical center to win the 5-star hospital ranking award from the Patient Safety Movement Foundation, which is just similar to Changhua Christian Hospital. He also received the Stephen Morrow Humanitarian Award in 2019. His major interest of research is so many, but to name a few, high reliability organizations, artificial intelligence, telemedicine, EICU, patient safety, critical care, and etc. So with all these backgrounds and achievements, we are fortunate to have his expertise and enthusiasm. So ladies and gentlemen, let's welcome Dr. Wilson. Dr. Wilson, please.
I was previously the Chief Medical Officer until the end of July, and as of August this year, I'm now the Senior Vice President and Chief Medical Officer for Masimo. And it's my pleasure to be presenting for you a lecture on high reliability and artificial intelligence in patient safety. It's also quite a privilege to be present here at the International Online Conference on Smart Healthcare Technology and Patient Safety. And I'm now going to share the screen and begin the formal portion of the presentation. On this slide, you can see the organizers, co-organizers, and advisors of the meeting. And I'd particularly like to thank Dr. Chen Mu-Kuan, the superintendent of the Changhua Christian Hospital, and Dr. Mingi Liao, the founder of the Taiwan Patient Safety Culture Club. As a way of disclosure, I'm a full-time employee at Masimo, and this presentation represents my personal opinions and does not in any way reflect official opinions or policy from Masimo. Our objectives today include review of the high reliability organization and how artificial intelligence can help. We'll spend a brief period of time just reminding each of you what artificial intelligence is, how it differs from machine learning and deep neural networks. And then we'll present a number of examples of artificial intelligence, most of which that occurred at UC Irvine. And we'll try and focus on those that are most relevant to the Taiwan Patient Safety Culture Club, as well as the Patient Safety Movement Foundation, as there's a strong tie-in relationship between both organizations, and the goals should be quite similar there. High reliability organizations are those that operate nearly error-free in high-risk settings. And avoiding mistakes in this complex high-risk environment is what we're going to be talking about this morning. HRO, or high reliability organization paradigm, includes aircraft carriers, nuclear power plants, commercial aviation. And the shared commonalities are these are complicated technologies at very high risk for error, and the consequences from errors preclude learning by experimentation. Thus, failures are avoided by using sophisticated processes to manage the technology and the work. The high reliability organization concepts are essential for patient safety and quality, as there are few things more complicated than caring for a sophisticated, critically ill patient. Artificial intelligence can assist in early diagnosis and detection of patient instability, and we'll provide some examples of how that's the case. Before you now are the actionable patient safety solutions, the so-called apps, that are part of the Patient Safety Movement Foundation training and experience. The Taiwan Patient Safety Culture Club has participated in the development of these apps, as well as in the propagation of training for hospitals in Taiwan and elsewhere. Today, we'll focus on Challenge 10, systematic prevention and resuscitation of in-hospital cardiac arrest. And we'll spend some time talking about improving diagnostic accuracy, that is reducing diagnostic error. Although it's not specifically listed as one of the challenges in the Patient Safety Movement Foundation yet, it is clearly an important risk for us. We'll start with the improving diagnostic accuracy, as this concept helps introduce the topic of artificial intelligence and will serve as an example in that regard. Artificial intelligence as a term was coined during a summer conference at Dartmouth College 65 years ago. Members of that group included John McCarthy from Dartmouth, Marvin Minsky from MIT, Herbert Simon from the Carnegie Mellon, Arthur Samuel, who was at MIT, Bell Labs, and then IBM, Alan Newell, who had been at Rand Corp, as well as Carnegie Mellon, as well as Nathaniel Rochester from IBM and Claude Shannon from Bell Labs. And those individuals are not pictured here. But it was that group that first coined the term artificial intelligence. This Gartner hype cycle for artificial intelligence gives a good idea of the expectations versus the time for a number of AI techniques and technologies. The typical formulation for which the Gartner hype cycle is based is you go through a series of processes. First, you innovate, and that trigger of innovation. Then there's a peak of inflated expectations, and then reality hits the metal when we realize there's more work to be done, rewriting programs, etc., through the trough of disillusionment. And then as things become better codified and organized, the slope of enlightenment, and ultimately the plateau of productivity. Some items involving artificial intelligence, such as autonomous vehicles, that's self-driving vehicles, not so long ago were up at the peak of inflated expectations, and then after a couple disastrous crashes, including the loss of life, is just now recovering from the trough of disillusionment and is starting to come this direction. Topics such as speech recognition have been well worked out and are in the very productive plateau phase of their work. Let's talk about some artificial intelligence terms and definitions. AI is defined as the theory and development of computer systems that are able to perform tasks normally requiring human intelligence. And it takes advanced programming and powerful computers to do this work. Some examples would be visual perception, speech recognition, etc. Machine learning is a subset of artificial intelligence that allows statistical models to be developed on data sets, large data sets, using powerful computational science concepts. Neural networks are machine learning models with an input and an output with one or more hidden layers in between. On the left-hand side of the diagram, we show a simple neural network, whereas when you have more complicated and additional hidden layers, you then start developing deep learning neural network models, multiple layers that process units. And it's interesting that often these layers in succession will transform the data into more complex and sometimes more abstract compositions. An example of how this works, this machine learning example and deep neural network, on the left is a preliminary early 1980s era with just one hidden layer. And over time, we've developed more and more hidden layers. And an example here would be a picture of George Washington, who was the general in charge of the Army for the United States during the Revolutionary War and later became the first president of the United States after the American Revolution. This picture can go into a neural network in a number of ways. First, the first layer, pixelated, dark and light, and then the next layer starts identifying various edges of the head, scalp, forehead, nose, and mouth, and then combination of edges, and then identifying features become placed in the hierarchy. And ultimately the output is, after teaching this neural network all of these various shadows, edges, pixels, if you put in on the input a picture of George Washington, the output will be that it is in fact George Washington. And rather than coming up with one of these other individuals, such as Benjamin Franklin here or someone else. So now let's look at how these artificial intelligence techniques are used in medicine to help increase diagnostic strength. And then later we'll talk about AI for decreasing the risk of patient decompensation and earlier rescue. First, I'd like to introduce Dr. Peter Chang and Dr. Daniel Chow. They're the two physicians that are leading the University of California, Irvine Center for Artificial Intelligence in Diagnostic Medicine, the so-called CAIDM, C-A-I-D-M. Each of these faculty member trained together in residency at New York Presbyterian, and they were both did neuroradiology fellowships at UC San Francisco, and we're very grateful to have both of them on faculty at UCI. The CAIDM, that is the Center for Artificial Intelligence in Diagnostic Medicine, was developed to envision and create deep learning artificial intelligence tools to improve disease detection, prediction, diagnostics, and therapy planning. And we'll provide some examples of the work done overseen by these two individuals coming up. One early study published by Drs. Chang and Chow is the early and rapid diagnosis of intracranial hemorrhage. And this was published in the September 2018 Journal of American Journal of Neuroradiology. Another is the radiographic evaluation of genetic elements that are specific for different grades of gliomas, brain tumors. And that work was published in the July issue of 2018 American Journal of Neuroradiology. In the case of intracranial hemorrhage, they were able to diagnose with 97% accuracy within 5 minutes. And the grade of brain tumor was accurate 94% of the time with utilizing techniques similar to what I described earlier. And in the case of the intracranial hemorrhage, which actually was the cover article in that September issue of American Journal of Neuroradiology, they taught the machine learning tool how to look at the edges of intracranial hemorrhage, the intraparenchymal components, the area around the ventricles, and they looked at what were considered true positives that are shown in green, false positives shown in the purple outline, false negatives over here in the blue. And when all of that was done and learning occurred, they then presented a number of unknowns and were able to come up with the 97% accuracy in near real time, that is within 5 minutes. Daniel and Peter, also doctors who lead the Kadam Institute, used their insights for developing an artificial intelligence tool to help with breast cancer screening and tissue imaging. Breast cancer detection now is improved by facilitating rapid detection of suspicious lesions using an automated 3-dimensional, 2-dimensional convolutional neural network using similar tools as was described earlier. They also have developed a way of identifying the fibroglandular portion of the breast, as that type of tissue is a known risk factor for breast cancer. So they allow easier stratification of that tissue. They also developed a system for diagnosing renal cell carcinoma and characterizing it in terms of the grade and severity. This technology optimizes the treatment of planning patients with renal cell carcinoma. Now, the topic of colonoscopy is something that's evolved over time. The American Cancer Society recommends that people at average risk have colonoscopy every 10 years starting at age 45. That number used to be age 55, it was 60, then 55, now 45. And if you have a large polyp like this seen on colonoscopy, it's very easy to identify and to sample. However, low profile flat polyps, as shown in this slide, can sometimes be missed. And some of those may be carcinogenic. At the UCI Health Comprehensive Digestive Diseases Center, one of the physicians has developed an artificial intelligence tool to help find these flat profile polyps. Let me introduce the team. On the left is Dr. Chang, who has developed the entire Comprehensive Digestive Diseases Center and developed it for 30 years. Next to him is John Lee. And then third on the list here is Dr. William Carnes. Dr. Carnes is the individual that worked with Drs. Chang and Chow to develop an AI tool to identify so we don't miss those low-lying polyps. Now let's turn our attention from improving diagnostic accuracy over to a more challenging problem, which is prevention of deterioration and then more rapid observation and resuscitation of patients in the hospital. You could prevent cardiac arrest and then resuscitate from cardiac arrest. This particular study by Lori Lee, Robert Kaplan, and others, published in the journal Anesthesiology in 2015, depicts a review of the anesthesia closed claims project database, where there's 9,799 claims. They identified 357 acute pain claims that occurred between 1990 and 2009 and looked for evidence of respiratory depression. They established risk factors for respiratory depression and evaluated the timing of events, clinical management, et cetera. And what they found was that 92 of these claims resulted in significant injury, 77% resulted in severe brain damage or death, and the vast majority of these respiratory depression events, that is 88%, occurred within 24 hours of surgery. The most profound finding was that 97% of these respiratory depression events were judged to be preventable if they had better monitoring and an earlier response. And the monitoring that they're recommending for this would be pulse oximetry, that is SpO2, and ventilation monitoring, as well as an assessment of sedation level, and then again, earlier response and intervention. One such tool for this work would include the patient safety net, as is shown here. On this large monitor, there are 20 patients being monitored. There are 5 columns, and in each column, there are 4 rows of patients. So that's 20 patients. This one is highlighted, and we're seeing the waveforms and additional data, as well as trend lines for that particular individual. Click on another box, and you'll have the same data for the other individual. These patients are wearing pulse oximeters, and they have various devices that we'll show in a moment. They can use the traditional tethered type, or they'll have some that can be connected to a portable unit such as this, and then using Bluetooth or Wi-Fi can be transmitted to a monitor and recorded. In addition, the data can be transmitted to a cell phone, so the clinician, either the nurse or doctor, can review the data on a particular patient from afar. In this study by Jean-Louis Vincent, published in European Journal of Anesthesiology in 2018, they reference that 66% of cardiac arrest patients show abnormal signs up to 6 hours prior to the adverse event, yet physicians are only notified about 25% of the time. In this study, they use multiple ways of monitoring a patient, not just pulse oximetry, but also heart rate, end-tidal CO2, and respiratory rate, and fed all of that data into a closed loop system to help determine when the patient would or would not be allowed to receive opioids during patient-controlled analgesia. And initially, the patient was able to give themselves a dose, these first 4 X's. But as that was occurring, the heart rate was coming down, the end-tidal CO2 was going up, and the respiratory rate started to come down. The stats were still maintained early because the patient then was locked out and not allowed to give themselves any more opioids, and allowed time for recovery of the heart rate. The end-tidal CO2 started to diminish again, the respiratory rate started to come back up, at which time they were allowed to get some more opioid infusion. This type of a closed loop was able to protect the patient, not allow them to have a desaturation event. Well, in addition to prevention of a unstable situation or cardiac arrest, we also have to train the teams on the A, B's, and C's of resuscitation itself. And on this slide, I show some images from UCI where we have been teaching individuals. On the upper left corner, you can see a team that is doing a simulation of blood transfusion on a C-section patient post-op. In the top middle is an actual resuscitation with a team working together. On the right-hand side up here is an example of me instructing some critical care doctors and residents on some of the basics that are demonstrated in the patient's physiologic data on the monitor. And down on the bottom is a debriefing after a simulation session with a group of doctors and nurses. So it's really important that you not only have the monitoring that we started to describe and will describe more, but also education and training on the resuscitation itself. We also want to recognize that medical care has become far more complex than it used to be. You used to be able to fly an airplane without a computer. Now you need lots of computers with all these jet engines. And similarly, you used to be able to take care of a patient with a lot of computers, but with all of this complex material and machinery, don't be surprised that a little bit of computer assistance in the way of artificial intelligence can help improve outcomes. We also have a bit of a double standard on weekends, evenings, and holidays. Those of us with the most experience are not around as often as the less experienced doctors and nurses. And there's abundant data in the literature, and I've provided some references here, that show that outcomes are much worse on weekends, on evenings, and holidays. Further, the nurses and the house staff are reluctant to call the attendings at home for proactive orders. And so wouldn't it be much better to have an awake intensive care doctor or intensive care nurse following patients for instability using alerts and tracking tools and artificial intelligence predictive models to help earlier interdict rather than leave it to a doctor to be woken up at home by reluctant nurses and house staff? So the answer is yes, and the answer is really a comprehensive system for remote monitoring and interdiction. And this is really similar to air traffic control, where you're trying to keep all these airplanes in the sky at the right glide path and altitude, keep them from bumping into each other, bumping into buildings or mountains. Similarly, we want to make sure that the patients are on their safe, getting better glide path. And this is done with remote monitoring. This is shown here. Well, what's the data for this? Is there data to show that it works? And yes, there is. One really superb study is this by Craig Lilly, published in Chess in 2014. They took data from 56 different intensive care units, almost 119,000 patients. And what they found was that comparing before they had the continuous monitoring to after they had the continuous monitoring, there was a 26% decrease in mortality in the ICU and a 16% decrease in mortality overall, and a decreased length of stay in the ICU, 20%, overall hospital decreased length of stay of 15%. Those are huge improvements, huge numbers, and they have been experienced by others as well. Now, here's an interesting paper published in Anesthesiology in the October issue of 2018 by Drs. Joseph Reinhardt, Maxine Kennison, and others. And it looks at the role of artificial intelligence in the operating room. What they did was they took arterial pressure waveforms and developed a hypotension prediction index. They recognized that from the arterial pressure waveform, one can determine rate, rhythm, preload, afterload, contractility, and they dissected the arterial pressure waveform first into the systolic phase and then the diastolic phase, and looked at all of the different waveform characteristics. Then they also took data looking at the systolic rise phase, the systolic decay phase, and then the overall decay phase. Similar to when we showed the picture of George Washington, where they took the external outline, then they took pixels, they took parts of eyes, parts of mouths, and full eyes, full mouths, and came up with, looking at from many different perspectives, and they taught the machine these various waveform characteristics. They came from different monitoring devices as well. They had 3,000 plus individual features, and there were more than 2.6 million combined features, coming up with a total of 2.6 million waveform features together. Machine learning and cool, they came up with the final predictive model. They also recognize that the arterial pressure waveform itself has a lot of data. And of course, this reminds you how the arterial pressure waveform is formulated. There's lots of pressures in the heart. And as there is isovolemic contraction, then the aortic valve opens and there's ejection of blood. And then when the pressure in the aorta meets and exceeds the pressure in the left ventricle, the aortic valve closes. That's a dicrotic notch. Left ventricular pressure comes down, but the aortic pressure stays up here. This is an example of the aortic blood pressure and the arterial pressure waveform. They also recognize that in addition to digitizing all this data, that when you have a patient who is in the operating room and they're anesthetized, and if they're deep enough that they're not breathing on their own, you have to ventilate for them, or if they have neuromuscular blockade, you have to ventilate for them. And in those situations, the arterial pressure waveform is fairly stable. But when you provide a positive pressure breath, there is a delta up of the arterial pressure waveform and then a delta down. And the larger the tidal volumes, the longer the inhalation time, the more PEEP, and the drier the patient is, the more systolic pressure variation there will be in the arterial pressure waveform. And there's a delta up component and a delta down component, and it's this delta down component that correlates most closely with the intravascular volume status of the patient. This phenomena was described by Azrael Perel several decades ago. It was summarized in a nice paper in Anesthesia and Analgesia in 2008 in the non-invasive techniques for evaluating this by Dr. Machard in 2005. All of those concepts and all of that data was utilized to come up with a training program for the artificial intelligence system. Some from the ICU, some from the OR, some from a multi-parameter intelligent monitoring intensive care database, the so-called MIMIC database, and some from the University of California Irvine database. And the system was trained, it was cross-validated, had internal validation and external validation. And then the patients were evaluated. What they came up with is a predictive model that could, for hypotension, that reproducibly predicted when hypotension, defined as a mean arterial pressure less than 65, when that would occur. When the HPI was in this 40 range, the patient was stable. Once you started getting up into this 90 range, then you had a very high likelihood that within 15 minutes, the patient would have a hypotensive event. There were some competing interests of the co-investigators, Doctors Hatib, Jean, and Booty, and Lee, and Settles, all were Edwards Life Science employees. Doctors Reinhardt and Cannison are co-owners of a patent for closed-loop fluid administration, which has been licensed to Edwards Life Science. Dr. Reinhardt is a consultant for Edwards, and Dr. Cannison is a consultant for Edwards, as well as Medtronics and Masimo. And Doctors Reinhardt and Cannison have received research support from Edwards Life Sciences. But nonetheless, they did a phenomenal study, and it's very interesting. Now, there's an emerging paradigm for cardiovascular monitoring that as we have new innovations and new challenges, these waveforms then get cut into the utilizing the processing power and accuracy of strong computers so that we can triage, use them to determine, is this an urgent problem or is this a normal situation or non-urgent? And that data then can be transmitted, can be shared across the EMR. Of course, we have to adhere to privacy, and we also have to adhere to ethics and evidence and the quality. And this whole system is reviewed in Nature Reviews of Cardiology. At Massimo, we're committed to improving patient outcomes, reducing the cost of care, and taking non-invasive monitoring to new sites and applications using these techniques and ethical constructs. In the same paper, there are examples of many sensors that can be worn and monitored from a patient in the ambulatory domain, as shown in the middle. And some of these devices are available for hospital care and home care as well. Skin patches, one example is the Massimo Radius T that continues to monitor temperature. Body sensors, one example is the Massimo Centroid that can tell the orientation of the patient and the decreased risk of pressure ulcers. They have various glasses like Google Glass, headbands, necklaces, rings, and items that go on ring fingers or other fingers, such as pulse oximetry. And this particular device, this pulse oximeter goes to a wrist transmitter that allows a lot of ability to ambulate in the hospital or even uses kind of a system at home. These wearable sensors are in fact quite available in hospitals now. Here's an example of a patient using a Massimo Radius system, where on the arm, the data from the pulse oximeter is recorded, and then it gets transmitted when the patient's in the room via Bluetooth to a monitor. The patient's outside the room walking around, it will go using the Wi-Fi. And you can monitor the patients quite well that way. There's even smaller devices, one such as the Radius PPG that doesn't need this large device on the shoulder or arm, but rather just the wrist watch, and by Bluetooth can go to a tetherless monitoring device, allowing more freedom of ambulation on the ward. And again, these can be used at home with the proper setup. So now AI is evolving from traditional just one data feed to multiple signal inputs. And with just a single data input, such as shown here, the question might be, is there an arrhythmia? Is there not an arrhythmia? Do we flag the doctor? But with artificial intelligence, we can look at things beyond just the arrhythmia. So yes, is there an arrhythmia? Also, is there a breathing problem? Also, what's going on with the end-tidal CO2? Also, how's the saturation? All this data can be looked at. Machines can be taught for various profiles that are consistent with opioid-induced apnea versus tachypnea from sepsis versus tachypnea from bleeding versus tachypnea from heart failure. Each of these, when you look at all these various data points, these various profiles become distinguishable. And once again, at Massimo, we're committed to helping to devise monitors that can go into this artificial intelligence program to come up with actionable solutions. At UCI, we worked very hard over the last 5 years to improve the safety and quality. And you may be aware that we went from a Vizient ranking of 61 in the United States 4 years ago to 43, just 3 years ago. And last year we were rated number 8 amongst all academic medical centers in the United States. And so far, with the first 3 quarters scored this year, UCI is ranking between number 6 and number 8 in the nation of all academic medical centers. That was through a lot of hard work and included even going through COVID. And with COVID, because of a number of factors, including artificial intelligence system that I'm going to describe in a moment, we were able to achieve the lowest length of stay and the lowest mortality of all academic medical centers in California and in the top 5 in the nation. These outcomes were the result of developing a respiratory care protocol very early, even before our first patient, and revising it frequently over time. using remote monitoring for patients throughout the hospital, the safety net, and then also allowing those patients that were not sick enough to need the hospital to go home on continuous pulse oximetry and monitor them there. There's an example of a patient at home using a pulse oximetry device that goes wirelessly to a smartphone, and it can be transmitted into the doctor that can survey it. They also have these wearable temperature devices to follow fever profiles. The patient safety net at home then continued to evolve to what we now call hospital at home, with individuals monitoring from afar. We also utilize monoclonal antibodies for those patients that had immunosuppression. We expanded our ICU capabilities. We went from 68 to 132 beds. We added 147 beds that were previously used just as clinic space, and put a military field hospital in our parking lot. All of these things help, but in addition, we developed an artificial intelligence predictive model for severity of illness. And it was once again Drs. Peter Chang and Daniel Chow, the co-directors of the CADM, the Center for Artificial Intelligence and Diagnostic Medicine, that help us develop this. Particularly Daniel Chow was working with me and others on this. And here's an example of the CADM predictive model that we use at UCI. We evaluate the age of the patient, the gender, comorbidities, their BMI, their respiratory rate, the white blood cell count, particularly the lymphocytes, creatinine, LDH, troponin, ferritin, procalcitonin, and CRP. And with those values are all evaluated, we can determine the risk of ventilator support or needing to go to the intensive care unit for each patient. And this helped, along with a clinical pathway we developed for patient care, to have the lowest mortality and the lowest length of stay amongst all United States academic medical centers. So with that review, I really thank you for your attention and time. It's very exciting that we have so many opportunities for improving health using artificial intelligence. And if we continue with this road, we'll have a much more reliable system, and we can get to the goal of zero deaths, zero preventable deaths, that is, by 2030. So let's work together and imagine similar quality and safety 24/7. What I'd like to do now is encourage anyone to join with any questions they may have.
Thank you for the very important
at this time.
lecture.
I do thank you very much for your attention.
Thank you, Dr. Changhua.
Oh, yeah, the time was almost up, so I'm just worried there's no time. You use up all the time allotted. Sorry, maybe we can have one question. Anyone from the audience like to ask one question? Just one? No? We understand Massimo makes very sophisticated monitoring devices, high-end, but they're not doing very good business in Taiwan. So I wish you good luck.
Thank you.
For the sake of patient safety. Once again, I thank you very much for making this very inspiring lecture. I would like to adjourn the session now. So
thank you, Dr. Liao. Great seeing you, and everyone. Happy to participate.
Thank you, everyone.
Thank you,
Dr. Zhang Liao, and Dr. Wilson's excellent presentation. Next presentation the speaker was from Johns Hopkins University, because of the COVID-19. they were on call for the duty, so he canceled this presentation. So we would like to invite him next time for presentation. Next, we would like to invite the moderator, Dr. Chang Hsu-Tung from the nursing department, CCH. She worked for more than 20 years. She received her master's degree at the US and also received her Ph.D. degree at the Kaohsiung Medical University. Without further ado, let's welcome Dr. Chang to introduce the speaker. Good morning. Today, I'm very happy to have this opportunity to invite Dr. Li Zuo-Ying to share regarding the trend of digital care and patient safety. Dr. Li at the moment work at the Zhenxin Hospital as the Director of Nursing Department, who is also the President of a Nursing Association. Under her career, she helped the hospital to develop the NICE system and the physics system and digital whiteboard. At the moment, Professor Li also teach in the university as a faculty to teach graduate students to develop the healthcare system. And her expertise is the tumor oncology and the Chinese medicine, as well as medicine informatics. So he's going to talk about the trend of digital care and the patient safety, especially the international trend and also the status here in Taiwan, how we nurture the nurses. Let's welcome Dr. Li. Professor, you need to share your PPT. You need to share your slides. And also you need to unmute your microphone. Professor, you need to unmute your microphone. All right, no problem. Can you hear me now? All right. Good morning. First of all, I would like to express my appreciation to the moderator, Dr. Chang, and also congratulate the CCH for your 125th anniversary, and especially on the information, health medical information is very important. I'm very honored to share this subject. So first of all, I'm going to present that at the moment, so-called the digital care, the trend of digital care. Before I start my presentation, I would like to elaborate regarding the nursing information here in Taiwan ranked very high. Every 2 years, we rank the global through the global nursing meeting. You can see we have a lot of participants. Also, our publication is also on top 3 level. And so you can see there this year we rank number 3. So we have very good remarks. So next I'm going to share regarding so-called global healthcare outlook. So there are several relevant to the nursing issues. At the moment, regarding the global development trend that started from 2018, we know it mentioned about that we want to invest on the digital technology. So such investment can reduce the cost and also increase access and improve the care quality. This was published in 2018. in 2019, it talked about the same 6 directions. Among them, it mentioned that we need to continue to invest in so-called the electronic healthcare technology and innovation, as well as the transformation of the technology to our daily life or our work. So this is the published in 2020. It mentioned that. So when we conduct this regarding the digital transformation, we need to help the system to have interoperability. So with the so-called digital transformation, there are some key issues, that is 5G technology and also AI, and also the natural language processing, and also IoT, Internet of medical things. So we also need to develop certain apps. And with that, it also reminds us that in the future, we need to think several issues. First of all, is that when with our job priorities, so that is something we need to consider which one is more important, and also regarding the investment as well as the resource in the hospital. And next is regarding the resource, where we should put the resources, especially the human resources. So we need to think about what kind of people we need to recruit, what kind of people we need to train, and how we train and how we retain the talents. In 2021, we have the latest the trend out of the 6. I want to highlight in red that this first is the same. We need to transform the digital care, and also it need to be have interoperable data. Due to COVID-19, we have a lot of telemodels, so and many care model cannot be applied through traditional approach. So next, I'm going to talk about under such a trend, and there are a few development key points. First is that we need to develop EMR, that is electronic medicine record, how to transform the data into the computer and then be digitized. Second is Internet of Things. As we say, that IoT development is very, very important with a potential commercial value. The third is the connected health, that is a so-called interoperability system. So through different systems in the nation, we need to be able to connect with each other. The fourth is business intelligence, BI. So when we talk about the information, we need to be this straightforward and simplified, and so help the decision maker to make right decision. And the next is AI, artificial intelligence. The previous speaker mentioned that this is something we also call precision medicine. So how we can help human beings to have early diagnosis and to have early intervention. So this is the most powerful function. The next is robot. That is to put everything, especially the program, under the robot to help to do the so-called economic medicine. These are the future issues. First of all, when start from data to information, so many people who are in information technology, you know, these are the 4 bricks, important technology to research and knowledge. And then now we take action. So all the development, so you need to take actions and all back to human beings. So for the welfare of the human beings. So when we have a data and the information, so we need to apply technologies. So to compile all the information and the data, next to put in a computer. So we need to think about the way to retrieve it and the nursing research. So through the research, we can generate knowledge to develop the trend. And next, we have many knowledges. So we need to compile them together and group them, and so we use the computer to do the algorithm, the computing. After that, so perhaps we can trigger certain models. So we know that which model we can do some prediction and create some wisdom and utilize such a prediction model to take certain actions. So next, let me go through the clinical treatment, so-called EMR, electronic medicines. And the first is the minimum data set. That is to say, when we input the data into in the computer, we probably need to divide it into small fragments or blocks. So then it is easier, convenient to retrieve it. So for example, when you register a patient, you need to collect certain data, and then in the unit we have 6 pages. So when the patient registered, you need to collect certain message. You can see these are formulated. So you can see it can be applied and integrated. So not only when the patient registered, when the patient is in a hospital, in the ward, you need to continue to collect data. So as the development, you need to apply or utilize the data. So you need to integrate the data. First of, in the beginning, you use a code. So certain code have certain meanings. So later on, when you utilize those codes, you can retrieve the data. This is a so-called application. The best is on the cloud. The benefit of cloud is that when you want to use it, each department can retrieve or download the data and utilize the system without a further input. This is the data management. So next, when we talk about IoT, Internet of Things, we talk a lot about many things. You can be on the person or on the subject. So you can transmit the data to the cloud through the computing, then you can retrieve it back to our computer and then to apply it. So for example, if we underneath the bed, we can put a plate that is a sensor, which is a sensor. You can sense the heart rate and the breath of the patient. So you can present this data on the screen. And then even the patient is can, go out of the bed, you can go to check and whether it's a fall down or it's really the patient walk out walking. And so you can use as a reference for quality management. At the same time, we can use this here, put a sensor. So whether if it is an infusion, then if the volume is low, then you will receive a signal through your cell phone to replace the infusion. So we also can put a beacon here. So on the whiteboard, you can present, say, so all the important devices are located at which ward. And then this is through IoT, Internet of Things, to manage the things. So under the COVID-19 pandemic, there are many developments. So because it's not convenient to go to the ward to have a face-to-face interaction, but you still need to monitor the vital sign of the patients. For example, here we use Wi-Fi to understand or realize that the heart rate of the patient. We use an IoT device to understand the status of the patients, or use a patch. Here you can see the temperature, body temperature of the patient through the monitor. Then you can pass it to the MIS, and this you click and you can know the patient's status in the ward and also their vital signs, etc., to reduce the chance or the need of a physical contact. So when we talk about, as I mentioned, the other key point is how to compile all those systems together, and so whether they can be interoperated. So for example, so you take the shift, so you don't need to open up the system or turn off the system and then switch to other systems. No, so this can enhance the risk between the systems. So you can lease or other many relevant systems linked together. So to our users here, you can have a very efficient integration. Either you take the shift change or individual shift, or you visit the ward, then you have the path to receive all those information together. I think this is something very important in the future. Based on my understanding, many hospitals like CCH already apply the efforts on this system development to make everything interoperable. So this is the key point. And so the other part is also like the use cutting edge technology to care the patient. People talk it night care and joke it to say night care. So when patients in the world. So you can monitor their activities. So use this information system to monitor the patients during the COVID-19 pandemic, whether the patient wear a mask or whether the patient need to receive certain support or assist to walk outside, walk around. So this is something we call proactive communication. Of course, we need the informed consent from the patients to allow us to monitor that. When the patient reject the 24/7 monitor, we can take this so-called passive surveillance. Here in Taiwan, most people use Line, social media, so we can join a group. So to collect certain data, the patient can send the data through the line to the nursing stations to save our time and then to have a more immediate response. This is very interesting. We provide this device. So she told us that this is very helpful, and so this is a lotion. So and the patient asks, "What is the brand of this lotion? This is very nice, and it make me feel very comfortable." So another one is that, as I mentioned earlier, because of the COVID-19 pandemic, so we changed our care model because of the pandemic. We have several relevant regulations. For example, for the outpatient visit, we can download the app, and then you can stay at home and communicate with physicians through this telemedicine diagnosis.
That will reduce the risk of infection in Taiwan. More than 8,000 medical institutions have such a system. This is BI, business intelligence. We put a lot of data into such a system. If we can display these data on the screen, that will accelerate the decision-making process. For example, this is for the ICU head of nursing. After the head open this screen, all the important data and information are displayed on the screen for the head to make the right decision. And this is the URL. You can log on to the URL for further details. You can see that this is some of the activities. The data displays the coronavirus risk case activities. Some activities are safer than the others. And this is the healthy life expectancy is increasing in almost every country. And through the visualization, the information is very clear. This is another example where is coronavirus rising and falling. You see the different countries. Through the visualization, you are very clear about what countries are safer than the others. Next, I would talk about the robot economic medicine. As I talked about earlier, robots can do a lot of things for us. This is 20 years ago. We went to this hospital, and 8 years ago, there was a pharmacy that built. A lot of the medication information was stored in this space. As you can see, the pharmacist was very busy. The benefit is that you can perform the task at any time. But if we can have a robotic system to replace the human labor, then well, that will reduce a lot of process time. For example, this is a robotic system for blood drawing, disinfecting robot, and also health education robot. In the future, medical institution, there will be a lot of work done by robotic systems. Yes, I was told about AI and precision medicine, as the previous speaker just shed some light on this area. We have accumulated a lot of knowledge at our institutions. How can we use AI and machine learning to examine certain combination of vital signs and other important data? For example, we asked the question, is it possible for us to predict the infection risk? If we can predict, that means we can have some advanced preparation. In here, you can see it includes 165 biomarkers. Such a model, I think, is quite futuristic. But the precondition is that physicians and nurses need to trust such a model since it covers so many biomarkers. So this is a Philips data set of over 41,000 hospitals. As you can see, the reliability rate is around 85%. That means that the model can predict infection up to 48 hours before observable the symptoms. So through these biomarkers, we can come up with such a predictive model for infection. This is another very interesting research. 70% of seizure patients cannot be predicted in home environment. That creates a problem in home care. Sometimes the patients are riding a bicycle or on the way to the airport, but the seizure happened. That's a very high risk. So scientists will think about whether or not AI could be used to come up with a predictive model. Through the smartphone or through some signal transmission, the patient can predict seizures will happen. As you can see, the accuracy rate is 99.6% through such an AI model. And here they analyze the brain activity using EEG. Through the IoT, the data can be sent to the computer system with a very strong computing power. And each patient can also understand his or her own risk. This is a great contribution to care for seizure patients. Next, I will talk about digital care and the patient safety. With all that said, how is the advancement of healthcare technology related to the patient safety? Let me go back to talk about the Taiwan. In Taiwan, we have a Taiwan's patient safety notification system, especially for some severe injury or death. You can see that around 1,400 patients, or 3% of the patient having this medical error resulting in injury, severe injuries or death. So clinically, you can see that patient may have bed sore or pressure sore, or you can see we have the issue with the setting of the infusion pump, or confusion about the two different medication because the bios look so similar, and also for the blood drawing, some mix up. All these can happen at our work clinically. Is it because we do not have the right SOP, standard operation procedure? Not really. Some hospitals have more than 100 SOPs. And we also have the different units, different departments at the hospital. Nurses need to follow the different SOPs at different units and different departments. So it is very complicated. In face of such a daunting challenge, maybe we need to think about whether or not technology can help us to reduce risk for patients. So the ERCI suggested in 2018, including top 10 safety concerns for a health organization. One of these suggestions is incorporating health IT into patient safety programs to reduce preventable injuries to patients. And also IOM in the United States indicates that in training students, nurses or physicians or the medical technologists, we need to have this core competency, 5 core competencies, including we need to provide evidence-based and also quality care. Last but not least, they need to learn how to utilize informatics. Informatics can help them perform their job better. From these pie chart, you can see that only 7% of organizations have fully executed digital strategy, and 2% have no plan or are taking any action on this. 32% are taking enterprise-wide changes. 32% are still gathering information or formulating a plan. So there's still a lot of room for improvement for medical institutions. Human brain has its limits. Strong computing power can help us. Artificial intelligence algorithm can help us to deliver better and more accurate decision-making process. So this is digital care. I would also like to share with you the one point. Hospitals have invested so much in this system. What can this digital care system achieve? Well, digital care improves patient safety and care the quality. So here, I actually wrote a paper. Let me share with you some of the results. We have been working on the nursing informatics so many years. Have we achieved better clinical outcomes? In here, this is the nurses working at the bedside, measuring the blood pressure and also blood sugar level. The data can be sent to our smartphone with one click or one touch. The data will send via Wi-Fi to our database, to the PPR system. Very clearly, we can see the trend line to detect whether or not there's any abnormal signs. These data can also be seen by physicians. Blood sugar and also in here, the graph will tell you what should we do next. Then these visualization graphs are very clear, neat, and easy to interpret and understand. That then reduce human errors. The second outcome is that through informatics, we can have better control. When you put all these data on the system, you actually can enhance the performance. You don't need to sit by the computer all the time. The recording system is actually provide better completeness. For example, TOCC. Before you go down to triage or diagnosis, and this is the nursing process records can be better controlled and monitored. That helps us to achieve higher care quality. The third outcome is through this barcode point of care system. We use a lot of barcode system from the medication dispensing, checking, and also specimen taking, collection, delivery. So we need to double check to ensure everything is accurately done. Reconciliation on the accuracy is a very important step that clinically we use this barcode system to achieve that. And here, if you go to this computer and look at this screen, and you scan the barcode, then you will see what drug this is, including the shape and also the color. You can double check to make sure that you get the right medicine for the patient. So this is how we designed the barcode system that has raised the efficiency and accuracy of the drug dispensing. Here, you can see the result indicators of patient safety and the nursing efficiency before and after system introduction. You can see the pre-test, the human error is relatively high compared to after the introduction of the system. From the near miss and also from the specimen error is actually reduced. Post-test 1, it actually shows that the drawing specimen error has come down to the 0 compared to the baseline. So through the visualization, you see a lot of improvement, and also for the specimen process time. In here, we have specimens spending more than 2 hours in transit. Before the test, 21% achieved this target. After the system is introduced, well, the 12%. And also the pathology specimen errors percentage. That means before the patient goes to the OR, you can see now after the test, it has dropped down to 0.01%. A huge improvement. And this is about the electronic ship handover. This is something I would use myself. This is second generation. In here, you can go to the nutrition system, surgery system and also other system to get more data. If you compare the first generation product to the second generation product, as long as we can achieve interoperability, the level of satisfaction of the second generation is actually higher because it has achieved even better benefits and outcomes. Integrated information communication system will be even more powerful. The head of nursing department will open the nurse system, and those nurses will pull into the system. As you can see, this is the nurse on duty using the cell phone. The patient at the bedside with the push on the button, the patient can communicate with the nurse. Even people working in the lab or in the OR that can also use the system to talk to this nurse. So this is the integrated system. Maybe you think, well, the nurse will be taking so many calls. Well, sometimes it is necessary because some information is urgent or is very important. With the integration of the different systems, we have a monitoring system every 6 months or every year. This is satisfaction survey in the past is not very good. However, with the integration, we can see that the level of satisfaction has increased substantially. So technology really can help us to deliver better quality of care. I talked about some application clinically using high technology. We also find that every year the nurses turnover rate after we introduced this system have dropped. Well, nurses will vote with their feet. And I believe this also enhances the image of the nursing staff of the hospitals because nurses now have a very good digital assistant. And that's why the turnover rate has dropped substantially. Let me make my conclusion. This is the model for the nurses. What the nursing and it's not science, it's art. This is a Nightingale. And of course, now we work with the technology. Technology also has its human side. We are facing technology, but as nurses, we are carrying humans. When we talk about the quality, there's Denabidon is the master. The secret of quality is love. Have to love your patient, love your profession. That's why we said in our community, you need to treat your patient just like your father, mother, your loved ones. Then we will provide a high quality care to patients. That's how we enhance the patient safety. That concludes my presentation. Thank you very much for listening.
Thank you very much for Dr. Lee this presentation, in her sharing, you can see that as long as you are human beings, we make mistakes and errors. However, through technology, we can reduce such the error and also help us closer to our patients. We're always looking for a safe hospital, either patient hospital or employee safety. I'm wondering whether any people on the line have any question regarding Dr. Lee's presentation. All right, so perhaps the presentation is very excellent. So I just want to ask Dr. Lee one question. As out of your career development, so you should have encountered certain challenges, right? So there are many junior staffs here on the line. So if you want to encourage them in one word, what would you say? Thank you, moderator. So actually, in the field of nursing is the same as other industry or sectors, because this is a very innovative path for the nursing informations, and so we consider you should set the ground zero and go back to zero, and then to absorb other people's comment, and then to open up your mindset, and then to how to take the perspective of the hospital to make the design. And I also want to remind people that when we receive the challenge, one thing we haven't learned in the school is that how to lobby your comment or your mindset and the knowledge to your supervisor and ask for the support, for the budget, for the acknowledgement. So whether they agree with you or not, if you have some negative impact, then you need to be perseverance and handle there, and you will see a bright future. Thank you. All right. Once again, thank you very much, Dr. Lee, for this fruitful presentation. I believe on the journey of technology, I think we all need a teamwork, and I wish everybody can have a clear picture about your role. And don't forget, you are a very unique person. Because of you, you can move forward gallantly. Thank you very much, Dr. Lee. All right. So once again, thank you very much, Dr. Hsu-Tung and Dr. Lee. Then we'll move to the final section. The moderator is the Dr. Chen Xu, from the Chief Information Officer of the Department of Information Assistant at CCH. Dr. Xu worked in CCH since 1974, so she is a very experienced person. Thank you, the chairwoman. So I'm very honored to serve as the moderator for this section. This section, perhaps the topic we're going to talk about is how to evaluate the effectiveness of smart healthcare input, how to conduct the assessment of the efficacy. So we are very honored to invite the person who are very renowned on the cross-disciplinary combining healthcare and IT with a dual expertise, Dr. Yang Zhongrong Yang. So to serve as a presenter, Dr. Yang at the moment serves at the Kaohsiung Veteran General Hospital, and he's in charge of a quality management center. He's a director and also have other duties in the hospital. Dr. Yang is a radiologist, and so in the imaging development, he has a numerous contribution, and so at the moment he is the consultant of the healthcare imaging the standard and the quality. He is a key person or key driver of the digital development at the Kaohsiung Veteran General Hospital. he is helped the hospital to establish the healthcare imaging system. He helped make the experts in the healthcare imaging to remotely conduct interpretation and the services. So this program initiated in 2006 and also received a Kaohsiung City's award from the Physicians Association. In 2019, Dr. Yang also helped to promote the program. So the Kaohsiung Veteran General Hospital to receive the National Innovative Award from the Bio Promotion Association, also received the Medical Promotion Association's award, and to help Kaohsiung Veteran General Hospital as a medical center, as a unique hospital, and also receive the Smart Hospital certification. So his achievements is well recognized. All right, so this section, Dr. Yang is going to give us 3 examples. One is quality, one is information, the other one is innovation. So through the innovative management and with a relevant index or milestones to invest the healthcare technology on the field, and to review the effectiveness of a smart healthcare input. So without further ado, let's welcome Dr. Yang. Good morning. My name is Dr. Yang Zhongrong. I work at the Kaohsiung Veteran General Hospital. I was a radiologist. At the moment, I work at the Research and the Innovation Center to serve my colleagues. Today, I'm very delighted to utilize some information with a participant. I was asked to talk about how to evaluate the effectiveness of a smart healthcare input. If the organizer asked me to share this topic 2 years ago, I don't think I'm qualified. But however, through these 2 years experience at the Quality Management Center, I'm very delighted and confident to share some of my experience. I kind of utilize the English to present the subject. That is how to evaluate the effectiveness of medical technology in the medical field. So I think use English to be more precise, to reflect the intention of the organizer. I think the key word is effectiveness, and then the other key point is technology resources under healthcare field. Before I start, I would like to use a very important painting to start and kick off. So this is a very renowned picture. The artist is Li Siqiao, so who paint this artwork. The subject is Dr. Landa. David Land used a skin graft to save a young child. This is Pastor Zhou Xingyang, who is a pastor in the church, start from 1951 to 1972, if I remember correctly. Now I'm the follower at the Chen Church. So though you see these 4 surgery, but actually there are 2. The first one was failed. Then the second operation was successful. Use fragmented or patched graft. I think this is a very important or key inspiration. So which means oftentimes the operation will not be a success and by just one trial. They always require multiple trials and tests so to achieve the goal. So basically now we need to have a very strong heart to help the brain to make decision, especially to review what kind of investment will gain the best benefit. We need to pass through a lot of failure. However, eventually we will receive a successful module. So when I work at the Quality Management Center and Innovation Center, my task is that the key is to identify the digital value at the Kaohsiung Veteran General Hospital and what are the digital assets. So I would like to use this try and the five, basically there are five major networks. The first is healthcare IoT. We call it AIoT and in medical field, so it's AIOMT. The second is the unified communication. We call it holistic unified unification, the communication, like how to connect the healthcare and to put on this brand new digital medical records. The third is to empower the patients to help the patient to have a better engagement. I think this is very important. So either so-called SDM or just wisely, and basically they are talking about this. So this is the smart decision. The fourth is virtual linked to the hospital. When we apply AIOMT and the unified communication, we can establish a brand new structure to help the patient, especially during the COVID-19 pandemic. We can integrate all the hospital's resources to provide the best benefit to the patients. In this meeting from the Joint Commission in Taiwan this March, I advocate that if there is an opportunity in Taiwan to establish a second medical center, it should be a virtual hospital. And then this is not the so-called tangible center, but it's the first virtual healthcare to integrate with the tangible healthcare. I call it orchestrated virtual health. So when we have such four major network structures, then we can naturally to converge all those automatic lean operations, for example, nowadays. So we want to establish tele ICU. In the ICU talents is very few, it's very precious. How to make the best use of those the ICU talents? I think if you go to the operation room, go to the emergency room, these are the area we need to work on development. So how to make it automatic and lean operation? I think there's something we can share with every hospital. So with regard to the AIOMT, patient engagement, and orchestrated virtual health, as well as automated lean operation are five major networks. This is our digital assets. Next, I want to share with you regarding the example from our apparatus department to utilize to evaluate the performance. The subjects utilize telemedicine to reduce the outpatient visit, a clinical visit for the long-term care, the institutes, the tenant. So the study started from 2020 October till March 2021. So we would like to use the class 3 medical center to share the resources, especially during this COVID-19 pandemic. We launched a so-called dermatology video consultation session. So we published this article. You can see basically the key is on these figures. For example, how to reduce the rate of outpatient visit by 4.5%, although reduce number of the staff accompanying the tenants to visit the clinic by 26 to 33 times, reducing the cost of attendance expenses, and also increase the number of agency affiliated clinics by a certain amount. So this is a relatively simple operation model to review the revenue. So if we apply the remote technology for consultation on the dermatology, the English name is study on the use of the telemedicine to reduce the number of visits to hospitals by residents on long-term care institutions. So when I drafted this article, I modified the title, how to evaluate the value of investment of telemedicine resources on residential long-term care facilities. So basically, I already conveyed this figure to the value, and the value is how to utilize the telemedicine resources on our long-term care facilities. So you can see that when we have a different the horizon to think about these issues, you can see the power is different. So we use from the perspective of Quality Management Center a lot of investment projects. When we review the investment project, we need to see what is the values. There are two parts. One is so-called financial investment, and the other one is the so-called resource investment. This is very relevant to the effectiveness. Well, for example, the human resource and on which project to increase the digital assets. So this is something we need to evaluate. So a lot of innovations need to be categorized. So there are three major innovations. The first one is sustained innovation, that is continuous, like iPhone 6, 7 until 12. It is upgrade to continue to improve. And the second is performance innovation. Basically, is during the process, we need to increase the value, but for the factory, for the business, they have innovative technology. In hospital here, basically, we have the first two. However, the most beneficial is the market innovation, market value innovation, how to create a new market that is we need to think about when we apply those technology resources. Okay, so back to see what is the healthcare field. So the subject say we use healthcare technology resources. So we need to review the or make assessment of the effectiveness. So we need to know what is the healthcare fields. So we kind of categorize in these 5 areas. The first one is to help patient care. The second is to justify medical spending. The third is improve financial outcome. That is to have a better resource, the forces to reduce healthcare costs. And then the fifth is most difficult, but it's most important. That is to improve clinical efficiency and the care quality. That is something we always want to do, to create some auditing and then to set up the milestone and to create a strong and powerful assessment. Then actually such an assessment approach you can apply on the various industry, not only just healthcare or hospital. So all the industry require this direction, either telemedicine or smart hospital, or so-called health insurance 3.0, even the precision medicine, precision health, or regenerative medicine, and the digital medicine. These are all the same. So they all require the resource of technology to make the performance assessments. I think you can all think about that. From this perspective, I want to give you an example. This is in the state, Mayo Clinic. As you know, this is a very renowned institution, very powerful. In 2018, they have completed an epic EHR rolled out with final go lives. So people suspect what was the budget. If you spend 100 million US dollars or 100 million NT dollars, that's something phenomenal. But they spend 1.5 billion to conduct such the project. So this is such a large agency with more than 90 hospitals and then how to review their ROI, return on investment, and the performance. This is something I have studied. So as of now, there are 3 years. You can see there are PNC, very strong group, and even from Ph.D. MC, from Lambda, from the platform to conduct a lot of digital healthcare reform. This is something we would like to review about this investment here in Taiwan. Actually, we are relatively small. Is it possible we can have a national budget of 1.5 billion on the hospital around the island? I think this is something we are looking forward to achieve. Therefore, so from the healthcare resource investment, I think from the perspective of quality management center, we need to know the patient flow as well as information flow in order to review the investment and then to put the money on the cutting edge. So I think so we should start look at three parts. One is RWD, real data, real world data. And the second is RWE, real world evidence, and the third is real world value, RWV. If we have cannot review RWD, RWE, and RWV. So the first one is where can we invest? So it's just like you just threw a stone in the dark. So when you make an investment, and also when you're looking at the value, you need to have 4 principles. That is how to review have a count of the list of the digital record, and also you need to understand what the APM point, the safety compliance, have a safety assessment. So when you all the data, then identify the position and the role, so you can make sure so-called the safety of the system exchange from different respective systems. And then you can have a system profile. So when you have an investment, you can know how to manage it. So then last but not least, you have to review the feasibility proposal as well as the value assessments. So the precursor is very important for the quality management to help the hospital to control the quality. So when you write the RWD, RWE, and RWV, combined with those 4 major principles, we can have a more feasible program to confirm that such a technology investment is beneficial to the hospital. And as a result, when we understand the whole, the smart hospitals, the definition, then we can apply the smart management. What is a smart hospital? The definition is that incorporated the smart element to reach 3 purpose. The first one is a better patient care. Second is a better patient experience. We have a better patient care to reach a better patient experience. You can see at least a 50% improvement. But the most important is how to, based on such a management direction, we can have a better operational efficiency. The first one, the first 2 are efficiency. Quantitative benefit. The other one is qualitative benefit. So now in Taiwan, we use a single project that is a payment market model. That's a very important role to help the culture become the same. However, in the future, we will change. So in the past, it's pay for service, and maybe it will change to pay for outcome or pay for value.
In the future, it will also fee for person. On other occasion, I also talked about the paid as you live. So in the future, we will have the more payment model that should. Regarding each investment project, we always talk about the return on investment. You can see that this is net value divided by cost of investment. This is a simple math to come up with ROI, return on investment. You need to understand the cost structure and also the profits. Not all projects can achieve outstanding ROIs. However, I hope that in the future, we will have BOI instead of ROI. That's the value of investment. As I said earlier, some investment project failed. I have seen so many failed projects. Not every day is a New Year Day. Over the past 40 years, you can see China's real GDP growth by 4 decades from 1960s to year 2000. This is a continuous upward trend. And also, now you see that from 2000 to 2020, this is a downhill slope. We have to think about where and how we want to invest in the future. There are 3 types of areas we need to think about. We need to understand the background in these 3 perspectives. That's proof of concept. Number 3, proof of work. Proof of the service. If we can achieve a consensus on these 3 areas, we can have much more objective reviews as an indicators to guide our investment decisions. This is a multifaceted approach assessment. I talked about we want to change ROI into BOI, covering financial, functional, social, and emotional dimensions. It boils down to one word: value. Value in financial dimension, functional dimension, social dimension, and emotional dimension. You can call this model a benefit estimator. That means we need to estimate the benefits from any investment project. Take my hospital, for example, Kaohsiung Veteran General Hospital. We work on the EMR, electronic medical records, since 1996. Before 2006, we actually used HIS. At that time, we put in a lot of efforts and investment to develop version 1. In 2006, we had a version 2, that's MF and HIS integrated with web-based packs. In 2008, the HIS of a hospital underwent transformation to be a fully web-based EMR. 2018. So this is a web-based system. This is the version 3.0. In 2008, after we took part in the project of the Taiwan Joint Commission, we had version 4. That's cloud first EMR. And now we have the version 5, this is cloud native EMR. From version 1 to version 5, you see differences and also improvement following this logic from the financial, social, functional, and emotional dimensions. So at different time points, we have the evolution of different versions, but still we follow such a structure. Technology has advanced very quick. Now we see a lot of Me Too products. Golden circle to us is very important, including why are we doing this? As I said earlier, market creating innovation is the core. It is more important than product innovation, process innovation, and service innovation. We also need to reflect the needs of the time to deliver cyber-physical system and integrated care space in our medical institution. So it covers why, how, and what. Our vision is to have a hospital at home, at a long-term care facility, and also at the homes of the patients. If we want to invest in this project, then what kind of assessment system should we have to evaluate the outcome? So hospital is home. Home is hospital in here. We need to have insight into patient's need that covers the healthcare, prevention, treatment, diagnosis. What kind of service need to be incorporated into such a structure? So we need to go through such a thinking process to decide future service flow and the process to deliver better patient safety experiences. And who are we comparing ourselves with? And also what place, personnel, and services are involved. Last year, at BTC, we heard about the importance and emergence of regenerative medicine, precision medicine, and the digital medicine. In next month, there will be more announcement by the BTC. Every year, so we need to follow the government policy to design our service model. I'm a Christian. I have learned a lot from the Bible. Let me share that I learned a lot from the Gospel of Matthew on digital twins. I also learned medical devices from the book of the Genesis, pain-free surgery, telemedicine, regenerative medicine, and also minimally invasive surgeries. Well, this deserves another seminar to talk about these in detail. At our quality management center, we developed our, and you can see that OWL represent collaborations without limits. What do we want to achieve from such a platform? We designed such a platform to achieve these 4 steps. For example, in step 1, year 1, we need to understand the actual needs of our pathology department. And year 2, this is the year for service goes live, including imaging, the ingredients for precision medicine, for example, digital pathological services. It covers standardized SR report. And also SR will be used for the saving and the access of the different objects. And step 3, we want to have the telepathology, the POC, and also step forward the DPA connection. This is a market creating innovation from our original intent to promote the concept of the who is my right pathologist. If we need to have a surgical procedure, I want to have the right surgeon and the right pathologist. It's just like people are always looking for those famous surgeons to perform the surgery. So who is my right pathologist is very important for patients. And secondly, we need to nourish the telepathology market and to consolidate the precision medicine dream. We want to see the dream come true based on such a market creating innovation, as I just talked about, in putting the digital resources in the institution. We need to go back to our original vision and intention. This is the planning of the platform for the pathology informatics. Here, it covers 2 layers, application layer, service layer. You have the standard, the DCOM server, Flask, and also HL7 FHIR code server. And at the application level, you have the imaging, radiology imaging, and also imaging processing, the different layers. Quality management plays a very important part in the operation of this platform to deliver value-added services. Any successful investment project needs a team, and also for the government, the academia, and the industry players to team up. So team here is a verb. That this is for my hospital. Now we have the R&D collaboration SOP, including initiation, kickoff meeting, signing of MOU, and also execution and the sharing of resources and outcome. This is the flow chart. The standard operation procedure. You see we have the signing of the MOU, followed by the major service agreement signing, and also the analysis of the work, and also the service level agreement. The last step, that's a signing of a contract, and also some intellectual property right issue need to be discussed in the last phase. This is the key point and the process of the technological transfer. Another very important flow chart, starting from the creative ideas, the original intent, to the research, assessment, and also the actual investment project, yes or no. And if it's yes, you will need to have our IMPB, IRR analysis. And you see the professional advice seeking. Also, we have the OGSN to announce the objectives. And we also have the design process to transform the organization and calculate the value. And any feedback will go back to the original step. This is the benefit estimation chart. It covers different parameters, including the stakeholders' benefits and also financial aspect, functionality. And we have the total score and also ranking. This is OGSM. So my hospital, we have our project, we have the highest level objectives and goal. And for the IT department, we developed a cloud native model, and it goes down to detailed level. For example, the CPAC, the upgrading of the module, and also quantifiable objectives. We have external strategy, internal strategy, 3 pillars: resource, time, and also we have the methods of measurement to evaluate whether our strategy is a success. This is the application of statement of work, and also quantifiable objective, and also the SMART principles. This also for your reference. In many digital projects, we also include OEE, overall equipment effectiveness, OS, overall service effectiveness, OPE, overall platform effectiveness. We even consider this in our original idea creation as a key performance indicators in here. This OEE, availability, performance, and quality. OEE calculation, we use A times P times Q. Very simple formula. For example, you want to plan the smart operating room. We use OEE, or you can call it ORE to evaluate the effectiveness. We have OEE, OSE for equipment and to services. Overall service effectiveness involves system availability, schedule compliance, expectation fulfillment value. That means you need to know whether or not you meet your original objectives. We also have analysis using different indicators in different categories, and we also have the peer comparison, and we come up with a general score. We have leading indicators, lagging indicators. For example, in here, you see the leading indicator, the numbers of anesthesiologists, lagging indicators, the pain-free colonoscopies, how many you have, and also the high-level healthcare services, and how many physical checkup. And here we also have RCC, leading indicators, ICU, number of days of the stay in ICU is one of the lagging indicators. We need to have the right awareness and use the right tools to provide good assessment and evaluation. So you need to develop the indicators. So in here, I propose these 4 dimensions as I talked about earlier. This is the indicator used in the whole institution accreditation, CDSS, choosing wisely, IOMT, technological transfer pattern, the licensing, resilience, patient safety, ICD, and also EMR. All these are important indicators for a smart hospital. And each indicator can be a topic for further discussion. We have this intelligent environment. The measurement for the intelligent environment, hospital, department, and also healthcare personnel. More important is intelligent patient measurement. That's the health literacy measurement to enhance the quality of services. I really hope that you can explore the BOI for your hospital value of investment. and using your own benefit estimator. To my hospital, KSVGH, we want to raise the level to build on the lean and AI, mercy, and courage, aesthetics, and humanity. This is the vision for our hospital. So hospital will become a medical institution building on lean AI, mercy, courage, aesthetics, and humanity. Thank you very much for your attention.
感谢杨创新长，那么这么精辟的演讲，我想这个我们线上
Thank you very much for that very insightful presentation. A lot of information based on our statistics. Actually, we have over 300 participants listening to your presentation. I think maybe they will have questions for you. Maybe the participants are a little bit shy. So this participant did not identify his or her name. This is a question. For the healthcare technology development, how can you ensure the privacy of patients? This is the question for you, Dr. Yang. Can you hear me? The development of an app is challenging. You need to take many dimensions into consideration. My suggestion is to adopt smart on-file technology to build your new app. What is this kind of the technology? File is a standard data model. It is the framework. If we can use this model to build a healthcare app, that means it covered accuracy and also safety and data security. At my hospital, we have been using this for 2 years. We have filed the app. In Q4, we will launch this app. This will be connected to our EMR. And of course, my hospital is a state-owned hospital. Using the smart on-file technology, we need to have the open IT certification. So in terms of authentication authorization done, the next step is for you to have better control on the process flows. If the patients are involved, I think we also need to factor in the ISO standards. That's 27,701. The best way is to comply with the standards. And such an app that can be well protected in terms of the patient privacy. It is very different from the old thinking. In the past, now usually we have the RWD maximum, but now PWA, progressive web publication technology is what we use. That means we can have a real-time update and authorization. So we benefit from the state-of-the-art technology with the third-party ISO certification that will build a much better protection layer. Thank you very much, Dr. Yang, for your response. Any other questions from the online participants? Seeing none, let me ask the first question I have. In your presentation, you talked about the digital values, DOI. When I listened to your presentation, I thought about digital divide. In Taiwan, we have the different hospitals of different scales. And these hospitals have different resources. So in the process of digital transformation, how can hospitals in Taiwan overcome digital divide? When we talk about investing in digital resources, healthcare technology, how can we help those hospitals, maybe medium-sized or smaller-sized hospitals, to perform the digital transformation? Or in terms of investing in the healthcare technology, what's your advice to hospitals of smaller scales? This is my question for you. Any thoughts? This is a very broad question, but this is a question deserving our attention. I worked for the Veterans Affairs Council. The chairman of the council actually launched a project in 2019. It is a pyramid adoption project. Under this project, we shared resources with the regional branches. Some are those long-term care facilities with very little digital resources. So in here, we do have such a pyramid project to share our resources with our branches. We also develop CPAC, cloud-based patient EMR for clinics. This is a cloud-based consultation platform, and we have the 16 facilities managed by the council, integrated into such a system, including the financial system. And all these cloud services are stored in our server room. What they need to have is to have the PC or just a browser to link to our EMR at our hospital. And of course, our hospital is a medical center. We are very fortunate to have the many digital resources. This is how we can help them. We have the different system, and also some of the clinical decision assistant system. We can share the resources with them. We can also provide a microservice to our EMR by different institutions. This is how we reduce the digital divide. I think in the future, Ministry of Wealth and Welfare, and also our National Health Administration will also build public cloud for hospitals of different sizes to share their resources. That would be a very new model, a new market. We can really maximize the clinical values. In the future, we will not be constrained by where we are, the location or the size of the hospital. For the regional hospital or clinics, if they use old EMR, in the future, if they can connect IoT and the smart healthcare, and we can help them to make it happen. My hospital and also other medical centers in Taiwan were more than happy to help them to build the online management system. In this past March, at the meeting of the Taiwan Joint Commission, I said that it will have an opportunity to have the 20th medical center. Well, I want that to be a virtual medical center, integrating all the resources of the 19 physical medical centers. With that, we can really deliver smart medical services. Thank you. Thank you very much for your response to my question. What I heard is that it's very important to have a rich father or rich parents. I believe that some participants are the executives of medical institutions. They also think about digital transformation all the time. So thank you very much for your response and advice. In Taiwan, we see the digital divide, different levels of digital transformation. For the medical centers, every 2 days, every 3 days, they announce their innovation outcomes. The leadership plays a very important role in such a process. This is a big challenge. That's why I asked the question. I think we are seeing the pathway for us.
You have one passage like this. So you can, if you need the help, you can go to Dr. Yang. So he is someone who can help you. So all right, so we will conclude this morning's section. I will pass the microphone back to the host. All right. Thank you very much, Dr. Hsu and Dr. Yang. So this morning's section will be adjourned. Please sign out, and this afternoon our meeting will start at 1:30. We'll open up the sign-in at 1 o'clock, and then please remember in the afternoon you also need to sign in and sign out. So after this afternoon's session, you also need to fill the satisfaction survey in order to receive the credit, especially for those of you who need to receive the full credit. You need to complete the questionnaire. Thank you very much. See you this afternoon.